Good morning, everyone. My name's Jenny Proimos. I'm a paediatrician adolescent physician, so at the other end of the age spectrum. But I'm here today to moderate a session on menopause and lifestyle for World Menopause Day, which is on Saturday, October the 18th. So this is being run by the Monash Centre for Health Research and Implementation, which is a women's health and implementation partnership across Monash University and Monash Health. And Monash and MICRI, which we affectionately call it MICRI. MICRI's vision is to drive better care, better equity, better health, and is focused on prevention and care to improve health, especially for women, girls, and their families. So a little bit about World Menopause Day. It's a really good opportunity to spotlight the challenges which are facing women during the menopause transition and to highlight improvements in research, education, and support. And this year's theme for World Menopause Day is actually lifestyle. So in the webinar today, we're going to explore how a healthy lifestyle can improve your physical health, reduce your health risks of moving forward, and boost your mental health during menopause. So we have three fabulous panelists who will explain how menopause impacts your body and share practical advice of healthy lifestyle challenges that can help you manage menopause and improve your well-being. Before we get started, I'd like to just do a couple of housekeeping things. Please feel free in the chat to add any questions you may have, and we will hopefully leave enough time, and definitely leave enough time at the end to answer your questions that you have. So we want to make this relevant and useful to you. And also, I would like to actually begin by acknowledging the traditional owners of the land on which we're meeting today. We are on Wurundjeri Boonwurrung land, and I pay my respects to their elders past and present of the Kulin Nation. As the traditional custodians of the land that we currently have the privilege of working on. But I also pay my respects to all the people of the lands on which you are all coming from, and acknowledge and welcome any Aboriginal or Torres Strait Islander people who might be on this call today. So as we get going, I might just share my slides. We have three fabulous speakers today, and we'll take them in turn. I would like to introduce Amanda Vincent, clinical professor Amanda Vincent, who is a clinician researcher combining clinical practice in menopause with menopause-related research, translation, and education. She's the head of the early menopause research here at MICRI and the lead endocrinologist in the menopause and menopause oncology clinics at Monash Health. Amanda is an investigator with the Centre for Research Excellence called World, which is around women's health, and a lead researcher on the Ask Early Menopause and Ask Heart Health apps. And Amanda today will be giving you a good overview on menopause. So take it away, Amanda. And Amanda, do you want me to stop sharing the screen and you take over?
Yes, please, okay. Jenny. Thank you for that kind introduction. And I'm just going to share my slides now, and hopefully you can all see those now. So I'm going to start with what is menopause. And this diagram shows you your uterus and womb with the ovary attached there in the little pink box. And a close-up of the ovary shows that it is full of egg cells, which are surrounded by follicles. And actually at birth, we have the total number of egg cells and the highest number that we're going to have throughout life. And we progressively lose these egg cells throughout life until by the age of 50, which is when the usual age of menopause in Australia, you have very few that are left. And at that time, your periods stop. There is an accelerated decline in the number of egg cells after the age of 35. And that's when we often see women have declining fertility at this time. Now, about 400 eggs are released as part of the menstrual cycle across your reproductive years, but most of these egg cells are lost through a programmed cell death, a process that's called...
Sorry to interrupt, we can't see your screen.
Oh, you should be... Oh, sorry. Okay. Can you see it now?
Yes, thanks.
Great. Okay, sorry, I'll start again. Okay, so just to highlight, that's the uterus or womb with the ovary attached, and within the ovary you have the egg cells, which are surrounded by follicles. And as I said, you have the highest number of follicles at birth, and there's a progressive decline in the number of follicles throughout life. And this, until when you get to the age of 50, there are very few follicles left at all, and at that stage, menopause occurs. And this slide just shows you the phases of the woman's reproductive life across their lifespan. And we start with your first period, which is called menarche, which occurs at about age 11 to 13. And that continues until we get to menopause, which is the final menstrual period, which occurs at about age 50 to 51. Although the age of menopause does vary between 45 to 55 years. Around the age of 45, although again that could be anywhere between 39 to 50, women start to go through the menopause transition. And it is this time where previously during the reproductive phase, they've had regular periods, but during the menopause transition, you have often very variable menstrual cycles. They change in flow, they change in frequency, you may skip periods. And then after menopause, it's a time where you have the postmenopausal phase with no menstrual periods at all. The perimenopause is that time covering the menopause transition and the first year after the final menstrual period. Now, menopause can also occur if both ovaries are surgically removed at any age. And early menopause occurs if you go through menopause between the ages of 40 to 45, and that affects about 12% of women. And premature menopause or premature ovarian insufficiency is where menopause occurs before the age of 40. Now, if we just think back to the previous slide, this slide shows you the hormonal patterns that are occurring across this reproductive lifespan. So during your reproductive years with those regular menstrual cycles, you have a very regular pattern of estrogen and progesterone cycles. But during the perimenopause, that time when your menstrual periods are changing, this is because your hormonal patterns are fluctuating. They can be high, they can be low, they can be very unpredictable. And it is also during this time that you have the onset of symptoms. During the postmenopause, after your menstrual periods have stopped, estrogen levels are stable and low during this time, and that persists for the rest of your life. Both these hormonal changes that occur can affect symptoms, but can also cause body changes as well. It's important to remember that not only are you going through the menopause transition and menopause, but you're also aging at the same time, and that can also have its own body changes. This slide summarizes the different symptoms that women may experience during menopause and the perimenopause. And really, menopause, those are the classic ones shown in red. And the hot flushes, night sweats, and vaginal dryness are those key symptoms that we see associated with low estrogen levels. Now, during the perimenopause, you can certainly have these symptoms associated with low estrogen, the menopausal symptoms, but as I showed you, you can have those really highly fluctuating hormone levels, and sometimes the estrogen levels can be very high, and that can be associated with sore breasts, with headaches, migraines, bloating, and as I mentioned before, this is also a time during the perimenopause when your periods are very irregular. After the menopause, as you move into your later postmenopause years, the vaginal and urinary symptoms are the ones that predominate, even though the hot flushes and night sweats may have resolved. Most women have some menopause symptoms, only 20% have no symptoms, and the average duration of hot flushes is about 7 years, although some women may have have them for longer. So what are the changes that occur with menopause with these declining estrogen levels? And these can impact heart disease risk in a number of ways, which are summarized in this slide. We know that there are changes in your insulin resistance and blood glucose levels, changes in blood vessels. Severe hot flushes and night sweats are a risk factor for heart disease. You have changes in your cholesterol pattern, so more of the bad cholesterol or LDL cholesterol and less of the good cholesterol or HDL cholesterol. There are changes in metabolism, and you'll notice an increase in your belly fat, that's weight around the middle. Mood changes, increased anxiety and depression can occur around the menopause, and these have been shown to be risk factors for heart disease in women. We also know that there's an increase in blood pressure and difficulties sleeping, which are a common complaint for women at the menopause, also contribute to increasing heart disease risk. The QR code we have that I'm showing there just leads you to some resources that we've created around about heart disease and menopause and midlife, what happens and what tips for prevention. There are also changes that occur at menopause that can affect your osteoporosis risk. So if you look at the little panels of bone, the two pictures of bone, instead of being those nice dense bones, the bones become hollowed out, much less dense, and are then more liable to develop fractures. And if we look at this graph, which shows the pattern of bone density across your life, we increase our bone mass during our growing years, teens, and into our early adulthood, reaching a peak around about 30. But what happens at menopause in women is that there is this accelerated loss of bone that occurs during the perimenopause and also into the early postmenopause years, and that can be a 2 to 5% decrease in your bone density during this time, and that is why 1 in 3 women over the age of 50 will develop osteoporosis. Not only with menopause, there are other risk factors that can contribute to osteoporosis. So physical inactivity, low calcium or vitamin D, low being underweight are all factors that can contribute to osteoporosis and are important lifestyle factors that we need to think about. So why is lifestyle important at menopause? Well, I've talked about some of the changes that occur in regards to metabolic health, and this is also true of brain health. We know that lifestyle can impact on mental health. Lifestyle is also important for cancer prevention. We all know the association between lung cancer and smoking, but also breast cancer can be affected by lifestyle. Physical inactivity, excess weight, and also high excess alcohol intake all affects your risk of breast cancer. I've just touched on before about the importance of lifestyle in relation to osteoporosis, but lifestyle is also important for muscle health, and David will talk a bit more about that shortly. We do know that smokers have an earlier onset of menopause, a longer and potentially a longer menopause transition. We also know that women who are carrying excess weight can also have problems with more severe menopausal symptoms. So lifestyle is, and we know that physical activity, healthy diet can also impact on your experience of menopause symptoms. So for a variety of these reasons, lifestyle is really important at menopause. And now we're going to explore some more details about this with the next 2 speakers. So thank you for your attention. I'll try and stop my sharing.
Thank you so much, Amanda. Can I just encourage people to continue to put Q&As in any questions that you may have in the Q&A box, and I think what we'll do is we'll do the 3 presentations and then do all the Q&As at the end. So with that, can I please introduce Dr. Samantha Kozica. Dr. Samantha is a research fellow and research coordinator here at MICRI at the School of Public Health at Monash University. She's actually a clinical dietitian by background and has more than 15 years of experience across public, community and private sectors. Her research focuses on improving menopause and pregnancy service delivery, preventive healthcare and women's experiences to optimise health outcomes. Thank you so much, Sam.
Thanks so much, and thank you again. Sorry, can I just check, is my slides on presentation mode? Can everyone?
No, they're on their PowerPoint.
Sorry. That's better. Thank you. Thanks so much for that. So I'll get started. Thanks, Jenny and Amanda and David. So weight gain during menopause. As we've heard from Amanda just before, menopause is associated with many negative stigmas: hot flushes, brain fog, weight gain, depression, low moods. There's not really many positive things that people have to say about menopause. But as a dietitian and thinking about this area a lot, I think that we need to reframe menopause and think of it as a transition phase that, while there are many side effects that can be very debilitating for some women, it's an opportunity to stop, reflect, and use this as a place to reset your lifestyle, given we know the strong association between
Sorry,
menopause.
excuse me, Sam. Sorry, you're still on, you're not on slideshow.
It's on slideshow on mine. Sorry. What about
Now we're on presentation mode, Sam.
now?
Now it's, yeah, that's
Okay, sorry about that. As a time to reflect, and as the Heart Foundation, the American Heart Foundation have said, this can be a stage of life which is a window for opportunities to make behaviour change. So while weight gain is very common, it's not inevitable. And the 40-something study that was conducted in Australia recently showed that 60% of women could avoid weight gain by making simple changes to their lifestyle. And these changes included things like increasing their exercise frequency and reducing their sitting time, but also in things like increasing fruit and vegetable intake, reducing high-fat snacks and sugary soft drinks, and making small changes that are achievable rather than having to change your whole lifestyle. So when we think about what is the right diet for lifestyle, as Amanda explained, menopause affects women very differently. Some women will present with almost no symptoms, while others will struggle significantly. So similarly, we all have different needs, and there isn't one diet approach for menopause. I think when you think about a diet for menopause, we need to think about it in terms of a diet that is sustainable and flexible, that supports our heart health given the high risk of cardiovascular disease, that prevents weight gain and supports bone health given the loss of estrogen that then impacts our bone strength. The Mediterranean diet is probably the most well-researched diet in the literature and has the strongest evidence to show that it is most likely the key focus for menopause. So what is the Mediterranean diet? A Mediterranean diet is a diet that is rich in fruit and vegetables, includes lots of nuts and seeds and whole grains and breads, legumes, pulses, and oily fish. So when we think of oily fish, we often refer to the acronym called SMASH, which is sardines, mackerel, anchovies, sorry, having a mental blank, anchovies, and herring, and trying to include 2 to 3 serves per week. It's also including lean sources of protein, such as poultry, eggs, meat, as well as dairy foods as well. And also for those that don't eat meat, things like tofu, eggs, nuts, and non-animal sources of meat. In exchange, it's exchanging saturated fat, things found in takeaways, foods for fresh produce, like we mentioned. It's focusing on increasing polyphenols and omega-3s, because all of these foods have an anti-inflammatory and antioxidant profile, which helps to reduce the risk and the symptoms of menopause. The Mediterranean diet is also supported by the European Menopause Society Journal, again highlighting its evidence base. So what are women eating? And let's think about, what does the Australian Dietary Guidelines say that we should be eating for women over 50? So as we can see here, the Australian Dietary Guideline presents foods in different food groups. As I mentioned, in keeping with the Mediterranean diet, the Australian Dietary Guidelines focuses on healthy eating, which involves a high intake of fruit and vegetables, whole grains, as well as lean protein sources. But when we look at the literature, we found in the Australian longitudinal data, not conducted by me, but a group found that despite the fact that we are encouraging the intake of fresh fruit and vegetables, less than 2% of women, Australian women, when they surveyed over 10,000 women, were actually able to meet the fruit and vegetable recommendations daily. Similarly, as we've discussed the importance of calcium today, only about 1% of middle-aged women were able to reach this recommendation. And as we can also see from the Australian Guide to Healthy Eating, as we know, menopause is often associated with a time of weight gain, but as we mentioned, can be prevented. The serving sizes for portions of how many serves we should be eating reduces. So if you can see, I'm sorry, the slide is small, but you can see the size serving for the grains reduces from 6 to 4, and the amount of protein per day recommended serves also reduces from 2.5 to 2. So it's highlighting that we need to include these important nutrients every day, but given that menopause often results in a slowed metabolism because of a loss of lean muscle mass, we also need to adjust our eating appropriately in order to prevent that weight gain. So protein, as many of you will understand, has received a lot of hype in the menopause space. People flogging protein drinks, protein powders, all these things are, filling our Instagram and Facebook pages. But I think we need to think about why this is. Adequate protein during the menopause transition is really important because the estrogen levels begin to decrease, which reduces our bone density and our muscle mass. And adequate protein intake enables muscle repair and maintenance, helps with bone strength, healthy weight, because metabolism is in turn associated with our protein intake, our hormone balance, and also if our metabolism is working as best as we can, that will improve our satiety and then prevent us from overeating. The recommendations for how much protein we need per day is variable based on your weight, but as a common rule of thumb, it's 1 to 1.2 grams of protein kilogram of body weight is per day. So if you're overweight, it's then adjusting for your recommended weight, and also being mindful that if we overeat protein, it's not a magical pill and not a magical food. Any excess intake will then actually lead to weight gain. So I think it's about splitting up the protein in each of your main meals, also trying to include it in snacks as well, but looking at the quality of the protein, and also remembering that the recommendations for a high quality protein need to be matched with resistance training, because if we don't do the exercise in combination, the effects of protein are not going to meet their full potential. Another key risk nutrient during menopause is also, as discussed by Amanda, is also calcium, vitamin D. When we get older, our intake of calcium per the Australian Dietary Guidelines actually increases to 3 to 4 serves per day, which is pretty high. So if you look on the right-hand side of this slide, you can see that a cup of milk is a serve, 2 slices of cheese, a cup of yogurt, 100 grams of almonds, sardines, tofu. So it's trying to include these meals regularly. And typically breakfast is a really good time and an easy time to get calcium in, be it, a yogurt with your cereal, a smoothie, or cheese in combination with other proteins and whole grains. Vitamin D, though, is essential, though, to enable calcium to be absorbed by the body. So we need to be making sure that we get outside and we get sufficient sun exposure, but then obviously weighing up against the the risk of skin cancer. So small amounts of sun exposure is all that's necessary. And having also what's really important is to have our vitamin D levels tested. So as a dietitian, I don't believe in just taking supplements for the sake of it. I think it's important to get tested and see for a clinical need rather than just taking a supplement. So to optimize our bone health, we need adequate calcium, sufficient vitamin D, sufficient protein, and weight-bearing exercises. So the key nutrition recommendations that I would think are the most important to menopause, as we've discussed, it's that reduction in that total amount of food consumed. It's reducing the intake of sugary, high-fat snacks, like, chips, chocolate, lollies. No one's saying in menopause you can't have that at all, but it's everything's in moderation. And in that study I talked about earlier, in the 40-something study, women were still having these snacks. It was just that they were reducing the frequency. It's also ensuring an adequate protein intake, even if you're a vegetarian, so then making sure you choose high quality vegetarian proteins, like soy-based foods, tofu, tempeh, nuts, eggs if you're not vegan. Adequate calcium intake, following those Mediterranean diet recommendations, and also regular exercise. But then when we want to put this all into practice, I try to think of how this can be done. I think we need to think of things in small elements. It's starting with a small change, but the small changes eventually add up, and they're realistic and they're sustainable. So changing everything all at once is not going to be sustainable, but adding things one at a time, implementing it, making it part of your regular routine is much more sustainable. The power of planning. Most of us at this stage of our lives are pretty busy, whether it's work, life commitments, children, family. So it's about setting some time away to plan. If you don't have if you don't have a shelf stocked and a fridge stocked with these healthy items, being able to quickly whip up a healthy meal or a healthy snack is going to be near impossible. Tracking progress is really important. It's that, that level of accountability and that motivation to change. It doesn't necessarily have to be weigh-ins. It could be measurements. It could be blood tests every, twice a year or something. And being kind to yourself. This is a hard stage of life. Things are changing. Things are out of our control, sometimes in terms of what's happening in our body. And it's accepting that emotional eating will happen. Slip-ups will happen. It's being aware of it, but not letting it overtake you. And, just remembering that, there's always tomorrow. There's always next week. And at this stage of life, seeking support from your GP, a dietitian like myself, and some counsellors to provide that support, as well as exercise physiologists, I think is really important in order to make these changes safely and to maximise and to optimise this stage of life. The Menopause Society has recently just released a whole range of really helpful, colourful infographics that are really useful. So I've just left the reference below, and on the right is also some very reputable evidence-based resources that may be of use. So thank you. And I'm going to stop sharing.
Thanks so much, Samantha. Very interesting. We're now going to move on to our last speaker, who certainly not least, who is Associate Professor David Scott. And David is an NHMRC Emerging Leadership Fellow with the Institute for Physical Activity and Nutrition at Deakin University here in Melbourne. And his research focuses on the epidemiology and the management of sarcopenia, osteoporosis, and obesity in older adults. He leads clinical trials of exercise and nutrition for optimizing physical function and independence during aging. And his recent work explores the role of digital health in supporting older adults to self-manage musculoskeletal health conditions. He's published over 250 journal articles and books and received over $8 million in competitive funding. And he's currently the chair of the Australian New Zealand Society for Sarcopenia and Frailty Researchers Sarcopenia Diagnosis and Management Task Force, and is an elected member of the International Osteoporosis Foundation's Committee on Scientific Advisors. So clearly an expert in his field. And I'm assuming, David, you will tell us what sarcopenia means. So David's going to speak to exercise for healthy muscles and bones. Thank you.
Thank you, Jenny, and thanks everybody for joining us today. Very pleased to be able to speak to you all. I recognise that exercise obviously has a role to play in other aspects of health as it pertains to menopause. I'll be focusing mainly on my area of expertise, which is our muscles and bones, but obviously happy to touch on other roles of exercise in the panel discussion. So I always like to start just by reminding people about what our musculoskeletal health conditions are, what we're referring to. Now, there's actually thousands of different musculoskeletal health conditions, but these are sort of three of the big ones that we think a lot about, particularly in aging. I always mention osteoarthritis when I'm talking to the community about osteoporosis, because I want people to understand that they are two different things. It's not something that everyone quite understands. So osteoarthritis is a joint disease, and we tend to experience pain with that and then severe dysfunction in the joint at some times, which can lead to us needing a joint replacement, like a hip replacement or a knee replacement. Osteoporosis is that fragility of bone, as Amanda talked about. And the key difference, I think, to recognise is that we don't feel osteoporosis. There are no symptoms to it. So our bones are weakening without any real sign of it. And unfortunately, a lot of people only find out they have osteoporosis after having a fracture, which is obviously the key outcome that we worry about when we see people with osteoporosis. Now, sarcopenia is a term that a lot of people are not familiar with. It's a relatively recently recognised condition, and it can kind of be thought of as the osteoporosis of bone. Essentially, It refers to as we age, we lose muscle mass. The function of the muscle becomes poorer so that we don't have the same amount of strength as we did when we were younger. And that can have obviously a number of concerns for our independence, how we move around the community, and obviously also increase our risk of falls. So taken together, the weak bones that we might have in osteoporosis and the weaker muscles that we might have in sarcopenia, you can imagine might be an issue for increasing our risk of fracture. We saw a very similar picture to this in Amanda's presentation, which demonstrates what happens to our bones over our lifetime. You could pretty much superimpose muscle over the top of this image and you would see the exact same thing, except that fortunately in menopause we don't really see the same accelerated decline in muscle mass and function that we see for bone. But I think what's important to talk about here and kind of one of the key messages I try to get out to the community is that we need to stop thinking of osteoporosis and sarcopenia and probably other age-related conditions as things that just happen when you get older, because there are things we can be doing from birth that can really shift the odds of whether we're ever going to really experience the significant consequences of those conditions. So when we apply that and think about it in terms of exercise, I think there's different exercise goals that we want to be looking at across the lifespan. So obviously in childhood, through puberty and adolescence, is the time where we accumulate the most bone and muscle in our lifetime. And we really need to be encouraging our kids to maximize that opportunity. So doing the things that ensure that peak bone mass and the peak muscle mass that they arrive at in early adulthood is as high as it can possibly be. And then throughout early adulthood into middle age, we want to be doing things that really just prolong that period where we stay relatively stable and we have sort of the same amount of muscle mass that we did when we achieved our peak, same bone mass for as long as possible. Then in older age, obviously we have a decline that's somewhat inevitable. We can't avoid it altogether, but we can do things to reduce the amount that we lose. And we can also, I think, really importantly, start to focus on preventing falls that can lead to fractures. And so there's slightly different goals in terms of how we address them with exercise. So in terms of what exercise we should be doing, if you look up older adults exercising on Google, inevitably you'll see images like this, people performing low intensity activities, which are all great things. Certainly I would not discourage anyone from participating in any type of exercise that they find enjoyable or meaningful for them. But the reality is that these things will do fairly little for our muscles and bones. So really what we want to be, I think, normalizing and encouraging people to think about the types of exercise that you see on screen here. And so the first on the left is progressive resistance training, which obviously is focused on building our muscle mass and strength. The second is balance training, which is obviously focused on improving that balance so we can reduce our risk of falls. And the third is weight-bearing impact exercise. So things like hopping, jumping, skipping that have some benefit for increasing bone density. So I don't have time really today to obviously go into detail about an exercise program for people, and obviously they will be very individual in terms of what's appropriate for different people with different conditions. But I would encourage you to scan the QR codes on screen if you're interested in any of this type of information. These are all guidelines from internationally recognised societies with a focus on bone health. They're all got some really great exercise advice for people, both health professionals and the general public. I will do a little bit of a dive into the Osteoporosis Canada guidelines because I think there's some really key messages to take away from those. And the first one is really their strongest recommendation is around the benefit of exercise probably coming more from doing balance and functional training to reduce the risk of falls. So it's not so much about increasing bone density because we know that realistically we can probably only get fairly small improvements or even just maintain bone density, which is an important outcome. But the benefit of that is probably not the same as what we get from reducing risk of falls. And if you think about the fact that 90% of hip fractures, for instance, occur due to a fall, if you can prevent falls from happening, you can go a long way to reducing risk of fractures. So they obviously recommend resistance training twice weekly in addition to the balance and functional training. They say that these activities should be, your core activities. And so if you want to participate in other types of activity, as I said, you absolutely should. But nothing really should be in place of your balance, functional and resistance training. In terms of impact exercise, the evidence at the moment is still not that strong for its benefits. Mostly because in a lot of studies it's been combined with resistance training, and it's difficult to tease out whether one or the other is really causing the benefit for bone density. But it is encouraged, and I think it's just something that people need to probably start to build the strength first if you're starting from the couch, and build up to kind of the moderate impact and high impact exercises over time. Also, really important to recognise that there are potential risks of exercise. They are very small, but for particularly people who've had a spine fracture in the past, or people who might be at risk of that, we do want to avoid certain types of movements. And the best way, I think, to ensure that you can do that is to talk to an exercise professional who has training on how to manage osteoporosis. Now, you get fairly similar messages from the Royal Osteoporosis Society in the UK. They focus on the three concepts of strong, steady and straight. So strengthening the bones, keeping your balance and protecting your spine. The Healthy Bones Australia guidelines are quite recent, and I think this is a nice little template that comes from there that gives you a sense of what a weekly exercise program might look like in terms of incorporating your resistance training, your impact exercise and your balance activities. And I guess I'll close with these take-home messages. So really encouraging you all to talk to kids and grandkids about thinking today about their muscle and bone health, because that's where our journey starts. Recognizing that the primary benefit of exercise for reducing fractures may be actually in reducing falls. So if you feel like the resistance training in the gym or the impact exercise is not quite for you, that doesn't mean that there's nothing you can be doing to potentially reduce your fracture risk, because that balance exercise, which is pretty acceptable to most people, and can be performed at home. You don't need to go to a gym. We would encourage you to talk to an exercise professional as you get started, but it's something that can make a real meaningful difference to your fracture risk. And then I guess finally, making sure that these become core parts of your routine and your lifestyle. All the other things that you want to do, whatever they are, cardio type exercise or other types of exercise, 100% encourage them, but we're trying to focus on making these a core part of what you do. So with that, I'll hand back to you, Jenny.
Thank you so much, David. Perfect. And so are you still sharing your desktop?
I just stopped sharing, I think. Yeah.
Because I can still see it.
Oh, can you? Oh, sorry, I'm sorry. Yes, you can see my desktop. There we go.
Yeah, great. Thank you. Thank you so much, David. Thank you to all three of you. Those presentations were really interesting. And we've now got about somewhere between 20 and 25 minutes to go through some questions. And there have been quite a few questions on the chat, which is great. And David, given that you've just started, I might start with you, because there's a few questions here around bone health. Is walking enough exercise for bone health? I don't like gyms and had a difficult relationship with exercise in my lifetime to date.
Unfortunately, I would say walking is not enough exercise for bone health specifically. So it just doesn't provide the loading on bones that we need for it to respond and break down and build up stronger. So I would encourage you to potentially look at other types of exercise. Now, it is challenging, I think, to do the amount of resistance training that you need to see an improvement in bone density without being in a gym. Like, there is obviously resistance training you can do at home, but usually you're using dumbbells, fairly light weights. You don't have the big equipment that you need to really lift bigger weights. So that can be challenging. I think, though, you know, as I talked about, the impact exercise, so doing some hopping and jumping type exercises at home, and then also the balance type exercise, which is something you can easily do at home, would probably be a potentially good way to try and do something for your reducing your fracture risk if a gym isn't really the place for you.
What about walking with a weighted vest?
Limited evidence that it's enough. Again, there was a study on weighted vests relatively recently, which didn't give us a lot of hope that that would be sufficient. So I would say, again, probably not sufficient for increasing bone density. Really what we're seeing is, yeah, people need to be lifting relatively heavy weights to see an advantage. The combination with impact training might be the key thing. So unfortunately it is just the reality that any kind of moderate weight or low weight type exercise in terms of resistance training is probably just not going to quite reach the threshold that we need to get the bones moving.
Great, thank you. Amanda, this one's for you. What causes hot flushes at a molecular level, and why do they occur?
So hot flushes originate in the brain, and patients say to me, oh, my thermostat is broken, when they're sort of often describing a hot flush. That's what they feel like, and they're not actually wrong. So in the brain, there is a temperature regulating center in the part called the hypothalamus. And it involves particular nerve cells, which are called Kandy neurons, KNDY. And these neurons are responsive to estrogen, and also influence the other parts of the body that are involved in dissipating heat. So if our core body temperature goes up a little bit, if you have a fever, if it's a really hot day, what will happen is there are processes in your body whereby you'll sweat and your blood vessels will dilate, so you'll look red. And these are the underlying mechanisms that are part of a hot flush, but it's when your normal mechanisms are occurring at the wrong time. And what happens in menopause is that these Kandy neurons, because of the low estrogen, they increase in number and they become more sensitive, so that little changes in core body temperature or unusual stimuli will set off this trigger of these neurons, which will then influence the downstream processes that will cause you to sweat and cause you to flush. There also seems to be evidence that your thermostat, your core body temperature, your thermoneutral zone, or it's sort of like your thermostat, actually narrows. So little changes in core body temperature that wouldn't have caused this flushing response earlier in life now does cause it. And there's also now medications that can be used which act on these Kandy neurons to treat hot flushes.
Great, thank you. Trying to spread the load. Sam, there's a question here that says, I'm surprised to hear that the recommended amount of protein reduces over 50. I've heard a lot of talk about increasing protein in peri and menopause. Can you speak to the evidence on this conflicting information?
Well, the recommended dose, it's more about, I think, when you look at the Australian Guide to Healthy Eating, it's more about the serve sizes, and then actually in terms of, it's the serve sizes. So then it's not necessarily about the quality and the quantity, but because our metabolism slows, we want to reduce the serve sizes, because excess consumption will cause weight gain. But actually, the literature sort of shows that it's really between 1 to 1.2 grams per day. But the average recommendation for most people is usually set at about 0.8. So it's not that there's a bit of a discrepancy, and the Australian Guide to Healthy Eating was published and is in the process of being updated. But I don't think it really decreases. It's just about your total intake reducing, but within your total intake, ensuring that you have adequate protein, if that answers the question.
Sure, thank you. And also, again, another question about nutrition. There's a lot of talk about fasting for improving metabolic health in menopause. Is there any evidence for that?
Just in September, there was a big white paper produced on nutrition and menopause, and the evidence is pretty scarce. So there is a couple of studies showing that it can be effective in preventing weight gain and in managing symptoms. But in saying that, that's typically done by a 5-2 diet, which means that you will eat normally for 5 days and then fast for 2. For most people, that's pretty tricky. And when you think back to kind of, principles of ongoing behavior, sustained change, we want things that are going to be achievable. So if it is achievable for you to ongoing do a 5-2 diet, then sure, I'm sure it can have positive impacts. But for most people, they don't actually want to fast 2 days of the week. So whilst it might be effective in the short term, long term, they're going to regain the weight when they're unable to continue that style of eating.
Great, thank you. Amanda, does menopause, you talked about menopause affecting blood lipids. Does menopause also affect, very high LDL levels? Can they be restored to normal?
What happens with menopause is there is this change that we see in the pattern in cholesterol or lipid profile. So your lipids increase, and as I said, you have more higher LDL levels and lower HDL levels. Now, that is probably accompanying the fact that you're developing this abdominal adiposity, so you're having this visceral fat. So this is particularly fat that it does gather around the middle, but it's actually visceral fat. So it's around the organs of the body. And that can certainly affect insulin sensitivity, so causing insulin resistance, and does increase your risk of heart disease, and probably is influencing why you're seeing those changes in lipid profile. So obviously there are dietary approaches to managing lipids. So the Mediterranean diet that Sam was talking about has been shown to help modulate that diet, and then exercise as well can also help to modulate lipid profile. So a healthy lifestyle will help to assist that. And I mean, there's a number of other factors. If you have a family history of high cholesterol, that may influence also your how well lifestyle can manage your changes in lipid profile, and you may need some medication if it gets to such a high point and it's not being managed through diet and lifestyle measures.
Thank you. Sam, as a clinician, how do you manage risky behaviours associated with regular weight checks and health, and balance that sort of preoccupation and weight, with disordered eating and eating disorders?
Disordered eating in this stage of life is really common, as is higher intake of alcohol and risk drinking. I guess for everything, I really believe in moderation. And also seeking support. So, having a team, I think this is a really good time to take check of your health and have a team of health professionals that you can rely on, be it a GP, an endocrinologist, exercise physiologist, and a counsellor, and being mindful, weighing yourself. I don't think there's any need to weigh yourself, excessively, but, if it's once a week or once a fortnight, measuring, waist and hip circumference, just so that you've got a marker in your mind about what is actually happening, a regular health check with, blood screening twice a year.
Okay, thank you. David, you haven't had a question for a while. What's your opinion on the Onero exercise program for osteoporosis prevention?
Yeah, for those not aware, Onero is a kind of commercially available exercise program specifically targeting bone health. It stems from a trial which was called Lift More, led by Belinda Beck in Queensland, who's a leading researcher in this field, which demonstrated significant improvements in lumbar spine BMD and a potential to, I guess, maintain hip bone density as well. So I'm an advocate for it because, in my opinion, it's the only commercially available program that is evidence-based, and so it's available to the public. There has been research studies that have demonstrated through similar methods that we can, as I say, get small gains in bone density or maintain bone density, but they haven't been translated in the way that Onero has to the point that it's widely available. Now, widely available is probably not quite correct because it is only offered in by people who are accredited by the Onero team. So I think you can go on the Onero website to look for if there's a provider in your area that you can go and see. But yeah, I'll certainly encourage anyone who's interested in it to give it a go. Because I think, yeah, at the moment, it's really the best thing that we have in terms of an evidence-based program that's available targeting bone health.
Thanks. And I might throw another question to you, David. And I'm not sure if you would, it's just disappeared on me. Hang on. Aside from exercise for bone and muscle, is there a preferred type of exercise for reducing visceral fat?
I mean, I think I would say that, weight loss is the best way to reduce visceral fat. It's kind of a long way around, I think, with exercise to reduce body weight. You have to do quite a lot of it, I believe, to really to be able to achieve it. But it can certainly help. It can certainly play an important role. But really, the best type of exercise, I would say, would be any type of aerobic activity, moderate intensity to vigorous intensity activity. And I guess if you're wanting to get to the point where you're seeing some weight loss or maintaining a healthy weight, you're probably looking at trying to aim for about 10 to 30 minutes per day of pretty vigorous aerobic activity. And so that can be a challenge for some people, but I think if you can get yourself in that kind of range, you probably would see some benefit. I'd probably throw to Samantha about whether you think, that your diet's probably your best approach as opposed to exercise.
I think it's really a combination of both. And also, I saw in the chat there was another a question about visceral, the central fat and why it changes. But that's as Amanda explained, because of the change in the reduction in estrogen level causes more fat to be centralized around our abdomen. But in terms of weight, I think it's aiming small. And even if it's we usually try and aim for about half a kilo a week. Most women from the age of about 40 will often gain about a kilo to half to a kilo a week. So we can prevent that gain and look at maintenance during the menopause transition. That is a win. I mean, I know a lot of women want to lose weight, but unfortunately, the only way to really lose weight is, as what David said, exercise more and really eat less, and being mindful of and tracking our progress.
How do dietary recommendations for women during menopause differ from those for individuals with obesity, specifically and in relation to perhaps improving sleep quality or reducing sleep difficulties?
I don't think the menopause has become a real buzz in the last couple of years. It's really changed everyone's opinion. It's starting to get talked about a lot. There's not really any strong evidence on any particular diet for any subsets of menopause. It's really that balanced, flexible approach that is sustainable and that fits within one's life. So if you are overweight, it's about working towards gradual weight loss, but making the changes that are sustainable. And the strongest evidence for all women with menopause, the most researched diet is the Mediterranean diet, followed by the DASH diet, which is quite similar to the Mediterranean diet, but the Mediterranean diet has a stronger evidence base.
Great, thank you. David, what would help would the type of exercise you're talking about help with bone density in smaller bones, for example, in the upper limbs, like wrist fractures, preventing wrist fractures and things? Like, is osteoporosis, sort of prevention across the whole skeletal frame, or is it just sort of in the weight-bearing bones?
It's a good question. There is some evidence that boxing type activity, so where you're actually getting the impact through the upper limbs, might actually play a role in protecting from, well, at least increasing bone density in those upper limbs. I don't think there's been anything to show that it might prevent fractures. So yeah, it is true that the exercise that we're talking about largely is focused on the hip bone density and the spine bone density, which hip and spine are sort of recognized as the most debilitating and severe types of osteoporotic fractures. So they're probably areas that we want to target the most. But certainly, yeah, I think in terms of the upper body, certainly I think lifting the weights using your arms and, your back muscles and other muscles is good, but and we'll have a benefit, but potentially a little bit of boxing, getting that impact through that type of activity could give some benefit as well.
Thank you. We've got a couple of minutes left, and Amanda, I might throw to you. How do you improve sleep quality during menopause?
So sleep is a huge issue for women at menopause, and sleep disturbance is a significant problem and has both, impacts in daily functioning, but also longer term health impacts. We know that poor sleep is a risk factor for heart disease, and there's actually some emerging evidence about poor sleep in relation to osteoporosis and increasing your risk of osteoporosis. So menopause can affect sleep per se, independent of just having hot flushes and night sweats at night, which wakes you up from sleep. So menopause, the low estrogen, it often means that you find getting off to sleep more difficult. You have more awakenings during sleep, waking you up from sleep, and unrefreshed sleep. So it's always, and the other thing is that sleep disorders such as obstructive sleep apnea and restless legs are increased in women after the menopause compared to women before menopause, and they often present quite differently to men. So when people think about obstructive sleep apnea, they think of an overweight man who snores at night and who's sleepy. That's not women, and that's not how women present. So I think that it's always good to see a health professional about, do you have a sleep disorder? Things that you can do yourself is to make sure that you have good sleep hygiene, it's called. So you go to bed when you're tired, you have a regular bedtime, a regular getting up time, you only go to bed when you're tired, your room where you sleep is dark and cool, you avoid caffeine or exercise just before bed, you avoid screens just before bed, trying to sort of get your brain and yourself ready for sleep. There's some really good information. The Sleep Health Foundation, I'll get them to put up. Thank you, Amanda's already put it in the chat for you, has some excellent fact sheets about this. The other thing is that cognitive behavioral therapy, and there's one specifically designed for insomnia called CBTI that has been shown to be helpful to improve sleep. But there's also cognitive behavioral therapy has also been studied in women at menopause, and it's been shown to improve hot flushes, mood, and sleep as well. And there's information about that on the Women's Health Concern, which is run by the British Menopause Society. They have a handout about that. You can do it guided by psychologists or also self-guided. There's an app that also has been shown with hypnosis that could also help with sleep as well. So there's a lot of things that you can potentially do.
Thank you. We're at the end of our hour, but can I just ask one last question, if you can answer it in 30 seconds, Amanda? Yes, Amanda. How long should women take HRT or hormone replacement therapy? And can you start, after you've had symptoms for a long time, or do you have to start early? How does it work?
It's not a 10-second answer.
No,
That
no,
is an
sorry.
answer. That is an individualised risk-benefit discussion with your healthcare provider. Basically, that's what I would have to say.
Great. Thank you so much, everybody. There are some questions that haven't been answered, but we tried to get through as many as we could. I'd like to thank you all for being part of this, and just to remind you that when the this video is done, that we will be putting it up on the MICRE YouTube site, and so you can watch it again afterwards and go through some of the detailing in further in more depth. So thank you everyone for attending today. Thank you very much to the speakers, to Amanda, to Samantha, and to David. Thank you very much to Amanda Hamilton for organising it on behalf of MICRE, and I wish you all a wonderful World Menopause Day on Saturday. Thank you very much.
Thank you.
Thank you.
Thanks, everybody.